Hello, class. Welcome to Chapter 1, Exercises, Medicine in Chronic Care. So this chapter is a pretty good overview of a lot of the things that we will be talking about, and specifically chapters 1 and 2 that we will cover for this next week of class is going to lay down the foundation for everything else we talk about throughout the course of this class. So why don't we get started from an ample quote from the textbook. The ability to do physical activity, be it physical labor or leisure time activity or recreation or sport, is one of the most central aspects of being a person. Wow, talk about a good line to start a textbook, right? And I think a lot of us would agree in this class, based on a lot of different things that you guys wrote in your introductions, which I've loved reading, by the way, thanks for sharing, is we agree with this statement right here. And I know I agree. Here's me, I can't believe this, but almost 10 years ago playing soccer. And that was just the sport that I grew up with and I loved and I still love, and I just don't play as much as I would like to. Um, but yeah, it really is one of the central aspects of being a human, being able to move, being able to participate in activities that we like. Um, and I saw a lot of you say different sports. We have a really cool, diverse class, it seems, from volleyball, football, possibly just fun activities like running, hiking, skiing, so on and so forth. Um, I think we all agree with that, and that is why it is so crucial that as people get older and or suffer from a chronic condition, the ability to do physical activity starts to decline, slowly leading to a loss of autonomy. So, I mean, most of us are young. Most of us think of this as, well, I mean, yeah, not being able to play your sport or to be able to run as comfortably or ski or do, whatever activity it is for you, that sucks, right? But for this older generation or people that do suffer from a chronic condition, the implications are a lot more serious than just not being able to play their favorite sport or do their favorite activity. As it says here, it slowly leads to a loss of autonomy, and and that is the primary cause that leads people to lose their sense of independence, their sense of, can I move around and do things on my own? Some of you guys in maybe the physical therapy world or in general the clinical world would call this activities of daily living or ADLs. And as you know, maybe from other classes you've taken, as the ability for people to do ADLs declines, then their quality of life just immediately shoots downward. And again, they lose their autonomy. Therefore, here's another quote from the textbook: the ability to preserve physical functioning sufficient to maintain independence is central to the human psyche. So, if you want, just in a couple of slides, what this whole class is about, I would say this is it. The whole goal of this course is to be able to help people do this, to maintain their physical functioning and, on a broader level, maintain their independence and allow them to continue doing things that give them autonomy in their life. So, why don't we get into it? So, um, here is the power of physical activity, and this is a very, very basic statement. I can go into all of the details if you'd like, but we know that physical activity lengthens life and enhances the quality of life of those who do it. No body tissue or system fails to see any benefits due to regular physical activity. And I'll just abbreviate that as PA from now on, so we don't get too wordy. And specifically for chronic conditions, exercise programs aid the burden of the chronic conditions, comorbidities related to chronic conditions, and disease-related quality of life. We will see this for each individual condition that we talk about this semester. We'll talk about exactly what exercise helps with for these different conditions, or whether it helps specific comorbidities due to them. And yeah, so we'll deal with this a lot more in the coming lectures for this class. So exercise is medicine, or EIM. You'll hear me talk about this a lot because the textbook talks about this a lot. And the whole idea of exercise as medicine is that there's many reasons to prescribe exercise for prevention for people. So, for example, averting coronary artery disease, that's what CAD is, in patient with hypertension. So that's a pretty good reason to tell them to exercise so that they don't develop this condition. Or for someone who's had a heart attack before, maybe you prescribe exercise to have them prevent a second myocardial infarction, MI. Also, it can help to slow the rate of decline due to certain conditions. So maybe you can't prevent the condition or prevent um, the disability, but you can help slow the rate of it. And good examples for this are functional capacity and cognitive decline, which again we will talk about in coming sections. Here's another quote from the textbook. It is clear that exercise functions like a medicine and has a far broader spectrum of application than any single medication. Exercise is medicine, literally. We're going to talk about this a lot, and I think it's one of the most fascinating parts about this whole course is that we're going to go over a lot of these like different medications that people take, that they're prescribed to take, and interestingly, a lot of them work because they mimic exercise. So when that comes around, I think that's going to be a really interesting thing to track, an interesting theme that just keeps popping up over and over again. And so, in many ways, literally, exercise is medicine. However, as many of you know, there probably are a lot of barriers to this. So, the main goal of the textbook that we're going to use, and we're going to call it CDD4 from now on. The textbook refers to itself as that, and it just means chronic diseases and disabilities, edition 4, um, is to help physicians use exercise as easily as medication. So, obviously, we're not in med school, right? All of you are, I believe, getting your master's, right? Um, I saw that a lot of you do have the goal to go to medical school, though, so I think this stuff will be very pertinent to you. Um, but we're going to take the physician's point of view for just a second. So, what are the barriers for why physicians, doctors can't just prescribe exercise like they prescribe medication? Well, the three main barriers that the book identifies is number one, it's a lot easier to prescribe a pill. So I've seen this personally in my life. When you visit a doctor and there's a problem, typically, this isn't everyone, but typically their first idea is, oh, there's a pill for that. There's medicine you can take for that. Um, yeah, for example, this is like something I'm not super proud of, I guess, but a lot of people deal with it. I went to a doctor for an annual visit, and this was a time when I was teaching soccer for my master's. Like I was teaching it as the activity course for my school. So I was outside in very hot California heat. Sun was out every single day. And then she told me I have low vitamin D levels, which I couldn't believe. But of course, the main, like the first thing she said is, yeah, you could just take supplements and you'll be fine. And I said, isn't there a way I can deal with this more naturally, or maybe if I go outside more? And anyway, that was a whole issue. But that's just one example where it's a lot easier for a doctor to prescribe a pill. However, I've put this in that point as well. Is it also easier from the patient's perspective too? I want you to maybe think of people other than you or other than your circle of friends that are very active. Because, again, from your introduction post, it's pretty obvious that you guys are also relatively active and you enjoy being active in your life. So maybe this doesn't pertain to you, but think about maybe parents, maybe aunts, uncles, cousins, different people, or maybe just your friends that aren't as active. Don't you also think that sometimes it's easier for them to just accept a pill instead of doing a lifestyle change to exercise more? I've seen this from people in my life. I mean, why, this is their reasoning. Why would you exercise for, let's say, an hour a day when you can just take one pill every day and it does the same thing for you? Now, obviously, we know it doesn't do the same exact thing, but anyway, just something to keep in mind. The second barrier is it's difficult for doctors to counsel patients on lifestyle. This is due to many different reasons, and one of them we will talk about a little bit later. But in short, they sometimes don't have enough time to get into it. I mean, how many times have you gone to a doctor for a yearly visit and maybe 15, 20 minutes late to your appointment, even though you're on time. And then they just sit with you for 5 minutes and boom, they're right off to the next patient. It's hard. It's not entirely their fault, but perhaps it's just difficult for them to find the time to counsel patients. Also, a third barrier that honestly we can't do much about in our role as, the exercise professionals or future doctors is many societies don't pay healthcare professionals for exercise management. And that's just unfortunate, but it is a main barrier. So why don't we continue with the barriers? So the reliance on pills from the physician's perspective eventually leads the patient to inadvertently rely on pills and be less active. So this is not a good cascade. They think, well, I'm taking medication for whatever problem I have, therefore I don't have to be active because the pill is doing what exercise would do. Um, Again, we know it doesn't work this way, but a lot of people believe this, so you should also keep it in mind. Also, a note for those of you, especially that want to go on to medical school and become doctors, your words hold a lot of power. The textbook cites that a doctor's encouragement is the number one reason people cite for what prompted them to quit smoking. That's powerful. That's amazing. So, can they use that same power to encourage patients to exercise and to change their lifestyle? They can, but again, what are you going to devote your time to, right? So, these are just a couple of things we should keep in mind. Now let's keep talking about EIM. So, exercise is medicine. It initially started in November 2007 by ACSM, which is the American College of Sports Medicine, in conjunction with the American mm, Medical Association, I believe, AMA. And their goal is to make physical activity assessment and exercise prescription a standard part of the disease prevention and treatment paradigm for all patients. Um, I have not checked this for MSU, but I know some college campuses also have an EIM presence, or they've taken it on. Like my undergraduate school had it. We had exercise medicine events every now and then for the faculty that would promote it. So maybe MSU has one. I haven't checked. That's my bad. But it's relatively popular. It's been adopted in over 50 countries, and it's a pretty good mission. And they continue today. So, why don't we talk about that in conjunction with our textbook? So, EIM in general provides guidelines for apparently healthy individuals who can safely complete activity. So, it's just very, very general um, guidelines. It's to promote population health overall. So, it's not specifically written for patients who have chronic diseases and disabilities or people who might need accommodations in these guidelines. In contrast, this textbook, CDD4, provides support for healthcare professionals who are working with persons who do require some accommodation for their chronic condition. So, you will see this often in the following chapters when we're talking about certain guidelines and recommendations. Um, yeah, CDD4 is usually what we're going to refer to because again, we're dealing with populations that likely can't complete the general population guidelines for one reason or another. So just note that little difference. Now, the role of a primary care physician. So there are three things that primary care physicians do. And also, I want to say, if you are not on track to go to medical school, if you don't want to be a doctor, don't tune out here because the textbook takes time to talk about the role of doctors just because of how influential they are in people's lives, right? But don't tune it out because you can actually use a lot of these ideas as well for how you coach people or how, you help certain populations in your career. So just a little note there. So one of the main things they do, as I've talked about already, is an annual wellness visit. So the main goal during this is to create and update the patient's plan for health and disease prevention. Um, I'm sure most of us do annual wellness visits, right? They kind of follow up with you and they say, "Oh, well, last year this was better, last year this was worse. Good job, you've gotten better," so on and so forth, right? So we kind of know about that aspect of it. And as we've talked about previously, the physician should guide the patient into regular exercise or refer them to a program. Um, Now, this specifically, the textbook talks about the doctors referring people to other places. For example, here's a personal example. My dad is he works in construction and just maintenance. So his work wants to see that he can do these roles, right? So when he goes to the doctor refers him to somewhere that can do a stress test, for example. There are many other examples that can happen um, for that point. But one thing we are going to talk about a little bit is that the exam should include exercise vital signs as a part of the health risk assessment. So I personally haven't experienced doctors ask too much about this, and maybe because I'm still young. Um, but why don't we look at that? So, the book has a really good recommendation for an exercise vital sign question. So, in terms of assessing moderate to vigorous physical activity, you can ask two questions that basically will tell you how active someone is, or I guess for the duration of time that they're active during a week. So, question one, on average, how many days per week do you engage in moderate to vigorous physical activity like a brisk walk? And question two, on those days, how many minutes do you engage in physical activity at this level? The whole idea is it's just two numbers that they're going to give you, and if you multiply those two, then you're going to get the number of minutes per week of physical activity. And we're going to talk about this in chapter 2, but 150 minutes per week is the general bar that we want people to reach. So if you multiply these two numbers and they're not meeting that 150-minute mark per week, then theoretically this should set off some alerts in your mind. If you're a doctor, maybe you actually note this and the system flags the person to be at risk of not enough physical activity. Um, I am unsure of the state of this now, but I guess some of the bigger hospital systems have ways to log this online. So the textbook mentioned that Kaiser Permanente um, had a way to log this for patients, and within a few years, I believe it was over 80%, over 90% of their patients have some number associated with their amount of physical activity per week. So this is a relatively easy way to track it. And again, for those of you not on the medical school track, this is a very easy thing you can do with your clients as well, with your athletes as well. Now, if time permits, this is ideal because as I gave in my example, my experience with doctors is they're in for your appointment for 3 minutes. You're fine, everything's good, keep doing what you're doing, and they run off to the next person. Again, not totally their fault, but those of you who want to be doctors, if you do have something like 5 minutes, ideally more than 5 minutes during an annual visit, then you should also ask the following questions to your patients. What would they want to do to be more active, and what barriers are preventing this from happening? This is meant to be a pretty good Kickstarter for brainstorming. Try to figure out, what kind of like, can we break some of these barriers? Are there options? Um, for example, one of the examples that the book gives is if they can't find time to exercise, usually because of either bad work hours or just, having two or three jobs that don't allow for much free time, maybe they can park a block away from their work or 2 blocks away and walk for 10 minutes to go to work, walk 10 minutes during their lunch break, and then walk 10 minutes back to the car after work is done. That's 30 minutes per day, 30 times 5. You see where we're going, right? You start to hit those minutes. So, these are some questions that can help you with this. And as I note here, it's not just for physicians. I think you should do this if you're working with anyone to get them to exercise, whether they're athletes who like exercising or maybe athletes coming back from injury. Or just as we're going to talk about throughout the rest of this course, very normal, average people who have chronic conditions that don't allow them to do what they want to do, to be active. Now, here we're looking at this really interesting figure, and I think I want this to stay at the forefront of our minds as we talk about the rest of the content in this course. This is called the downward spiral of chronic disease. Um, and frankly, it's serious. This plagues a lot of people, especially in this country, but all over the world, right? So you start off in good health, and then depending on how your lifestyle is, or if you experience misfortune, or there's some socio-ecological risk or biological risk, your genetics, it starts to downward spiral into you developing different chronic diseases and disabilities. And unfortunately, what we see is that as you develop one condition, things just get worse and you develop another condition, and then you develop another condition, and then another one. Now, I want you to know at the top over here where we have, these four things, or I guess five things right here. Note the ones that you have the ability to impact and the ones that you don't. So often you can't do much about your genetics. You can complain to your mom and dad if you want, but can't do much about that. Can't do much about biological risk. Right. So, some of the conditions we'll talk about, men are affected more than women. Others, women are affected more than men. Others, it's just more common as you age. So, there are things like that that you can't change. Or if you have a family history of certain things, that's why doctors ask for medical history, right? Um, Socio-ecological risk maybe can kind of impact that. Sometimes you can, sometimes you can't. Sometimes you live in a place where, for example, going on a walk isn't ideal, isn't safe. I mean, I haven't seen it yet, but Montana winters can be pretty rough, right? So maybe you don't want to suggest a 70-year-old person to go and take a walk when it's icy out. Um, but you can impact your lifestyle, right? At least to a certain extent. Um, and yeah, so just maybe note that and keep that at the back of your mind as well when you're talking about when you're talking to certain people, clients you're working with, patients you're working with, athletes you're working with. There's a number of things that they can influence and things that they can't. So why don't we look at an example of this spiral? So this is the example the textbook gives. So for a person who develops a chronic condition, um, they become vulnerable to becoming increasingly sedentary, right? So let's say they develop some type of a chronic condition, whatever it may be. That leads them to be active less due to that chronic condition. And then that in turn leads to lower functional capacity, reduced gait speed and lower extremity function, loss of independence. That negatively impacts their quality of life, increases their risk of excessive weight gain. And as we know, once you gain it, it's a lot harder to lose it. So they could develop things like type 2 diabetes, other cardiovascular disease, and then all of this leads to eventually having deterioration toward being disabled. And like we talked about at the beginning of this chapter, you lose your independence and autonomy, and that is often the thing that people value the most in life in general, right? So, um, it is ideal that we attack this before it spirals to this point, right? Hopefully you can help people not develop chronic conditions, but if they develop the chronic condition, hopefully that is where exercise can step in and kind of like stop this downward spiral, right? So that's the main idea here. And now just some final considerations as we move on to chapter 2 in the next video. The CDD4 recommendations for a majority of patients with chronic conditions is not different from guidelines for apparently healthy persons. We'll talk about that a lot more in chapter 2. And considerations need to be taken with the barriers to exercise for those with chronic conditions. So this was just a general overview. The next chapter, we're going to talk about actual guidelines and what these CDD4 recommendations are that we've mentioned so much now. And we'll also talk about exercise prescription and two different ways that we can do it. So I will see you guys in the next video.